joining at a pretty fast clip here, so. All right. Let's go ahead and get started. I'm Sean Parkman. I'm the vice chair of the PEBB board, and today, if I'm not mistaken, Kimberly Hendricks, our chair, is not going to be able to join us, so I'll be facilitating. So the first order of business is to just take roll. We are expecting to have a lighter attendance today among our board members, and so there's a good chance that we're going to have a quorum. That should be fine. We may have to put off the approval of the minutes, but I think that was the only thing we were going to take sort of a quorum vote. With that being said, let's go ahead and just take roll and figure out where we are. So just verifying here, Kimberly Hendricks is not on the phone, correct? No. Okay. Kate Ness.
Hey, Sean, I'm here.
Oh, hi, Kate.
Hi.
Dana Parganani. Nope. Kim Harmon.
Yes, good morning.
Good morning. Mark Perlman. Not hearing Mark. Siobhan Martin.
I am here. Good morning.
Good morning. Jeremy Vandehay. Okay. Senator Betsy Johnson. Not hearing the senator. Representative Andrea Salinas.
Hi, everyone. Can you hear me?
Yes.
This is Miranda Miller, her chief of staff. She's unable to join today, but I'm listening in her stead.
Thank you. Thanks for making yourself known.
Yeah, totally.
Okay. So Ali, does that mean we have 4 people, including myself?
We're one off, but Mark may join late. So
okay. Well, if anyone notices that Mark joins, maybe we can loop back to the meeting in minutes. So we have a full agenda today. Our first item is the COVID-19 vaccine updates. Is there any other business for the board just before we launch in here from the board members? Okay. Just a reminder, this is a public meeting and we are recording this. With that, I believe that Moda is up first.
Good morning. This is Dr. Singh, Moda, along with Erica Hedberg. We'd like to provide a brief update on COVID-19. Globally, there are now approximately 190 million cases and approximately 4 million deaths. That's almost a million more deaths in just the last couple of months. We're seeing the start of the 4th wave with cases rising across the world. It is yet to be seen if this wave reaches the same peaks as previous waves, however. Over the last few days, the US is leading the world in new cases, again hitting the highest number of daily cases in the world. The UK also amongst the next highest numbers of increases. And although most cases are being seen in those who are unvaccinated, cases are also rising in those who are vaccinated. India and Brazil have it largely under control for now, though many other countries are seeing very significant increases. Indonesia, Russia, Mexico, for example, are experiencing vertically upward trajectories in terms of case numbers, as is the United Kingdom, despite its relatively high vaccination rate. Looking at the national picture, approximately 34 million cases to date, with around 610,000 deaths. Vaccinations have almost leveled off at just under 50%. Although the counts are only a fraction of what they were during the height of the pandemic, almost all of the states are reporting increases in case numbers, hospitalizations, and deaths over the last few days. The percentage increases are of great concern. According to the CDC, infections soared almost 70% in just 1 week to over 25,000 new cases per week. Weekly hospitalizations are up 36% in just 1 week. Deaths are lagging and usually rise as cases and hospitalizations rise. The CDC director referring to this as a pandemic of the unvaccinated. Mask mandates and lockdowns are returning in some locations that are experiencing a surge in cases. The Bay Area counties are now recommending masking for everyone indoors, for example. Looking at Oregon, we have had approximately 212,000 cases to date, around 2,800 deaths. At around 55% of the population vaccinated, we're faring a little better than the national average of around 50%. But again, this is largely leveled off, which poses a great ongoing risk to those unvaccinated and everyone else. Cases have risen 54% in the past week here in Oregon, with over 700 cases just over the weekend, with 9 new deaths. Most counties are seeing very significant increases. Looking at our PEBB member data breakdown, so in terms of testing, distinct members tested for active COVID, that's 5,297. The number of tests for active COVID was 8,220 in totality. Distinct members tested for COVID antibodies was 381, and the number of tests for COVID antibodies in total is 393. In terms of case numbers, members with a COVID diagnosis to date, 445. Members with an ER visit was 60. Hospitalized was 23. In ICU was 11, and we're aware of 1 death. Costs to date, testing costs around $813,000. Treatment costs around $1.19 million. Total vaccination costs paid amount was $415,969. This is likely underreporting due to reasons discussed previously. The biggest concern currently is that vaccination rates are slowing down due to vaccine hesitancy. Of course, the other major concern at the moment is the spread of the Delta variant of SARS-CoV-2, also known as B.1.617.2. First identified in December 2020, as fast spread and become the most dominant strain in the US and much of the world. Early findings are showing that it is much more transmissible, causes more serious illness, and has the ability to some extent better evade our immune systems, including the immune response triggered by vaccines. Vaccination is the best possible protection against the Delta variant, and although some fully vaccinated individuals are still getting infected, we know the vaccines are highly protective and are reducing the chances of spread, serious illness, and death. It's therefore critical to address vaccine hesitancy and step up efforts to increase vaccination rates through interventions that resonate with specific populations. Vaccination protects individuals, society as a whole, and reduces the pool size within which even more serious variants could emerge. The latter would also need a more concerted effort to increase global vaccination rates from the current lows of approximately 13% fully vaccinated worldwide. Obviously, practical measures such as distancing, avoiding crowded places, hand washing, mask wearing, etc., will always help against coronavirus and against all infectious diseases as a whole, and should always be considered. Thank you.
Any questions for Dr. Singh?
So this is Siobhan. I just have a question. Is this when we're going to get into the vaccination rates for PEBB, or is that somewhere else in the agenda?
It's actually in the Mercer report, Siobhan.
Okay, so I'll wait till then, till we get there. Thanks, and I appreciate that very sobering report.
Dr.
Thank you.
Singh, you mentioned underreporting. Maybe you or Erica could talk just for a minute about that, because I know it is kind of an issue and it's hard to really see some of the vaccination numbers is real solid numbers.
Yeah, and actually, Dr. Singh, I'll take this one. We do know that our vaccination rates are underreported, and there are a few reasons that we're aware of for this. One reason is because some members aren't providing their insurance cards when they get their vaccine. So for example, when I took my daughter in to get her vaccine, and they didn't ask for her insurance information, there was nowhere to put it, so we never provided it. And what providers can do is they can get reimbursed for the administration of the vaccines from the federal government, or they can bill that administration cost to the carrier. So either way, they can bill it either way and still get reimbursed. And then also we are aware of some providers who are holding on to the vaccination data. And so we just don't have complete data. When you do look into our vaccination rates, when Mercer gets into the utilization report, you'll see that our rates are considerably lower than the other carriers. And we think one reason for this is because we have not yet obtained the alert data, which would provide vaccination status for members who we don't have claims data for. So we are in the process of obtaining that data. And then as soon as we get it, we can provide updated vaccination rates to the PEBB board.
Thank you.
Any other questions for Moda? All right, thank you very much. Let's go on to Kaiser.
Great. Good morning. This is Keith Bachman, and I'll provide an update. Really the same overall global trends and statewide trends that Dr. Singh mentioned, with really concern over the last few weeks, though starting at low levels, but seeing increased levels of disease activity. As of last few days, currently within our healthcare system, 67% of members aged more than 12 and 68% of members 16 or over have received at least one vaccination. For our PEBB members, those numbers are essentially identical, though PEBB employees or PEBB subscribers, the current vaccination rate is 74.5%. We're closely tracking disparities related to race and ethnicity, and we're actually seeing in our Kaiser population lower levels of disparities, but any disparity continues to be a problem. We're seeing the gap between white and Latinx members decreasing from 15% to 5.6%, and the gap between white and Black members decreasing from 17% to 11.9%. Consistent with the Oregon statewide statistics, we see significant variation by county for Kaiser Permanente members. In our East and West Portland metro area, rates are 75% and 78%, while in the Mid-Valley, including Salem, the rate is 64% of people who have initiated a vaccination series. Efforts right now are really to make vaccination easier, normalize it, have conversations about vaccination for our patients who are vaccine concerned or vaccine cautious or vaccine hesitant. Most all of our medical office buildings are providing vaccinations. We're making sure that all 3 vaccines are available in each service area. We're ensuring that all our office buildings providing vaccines have it available on a weekend day. And we're continuing to partner with community organizations to help get the vaccine out in the community. The goal there is to make it easy, have it when someone is interested in having it, just make sure we can quickly get them an appointment for it or get them the vaccine that day. In my exam room, just like we do all of our other preventive services, we can see very easily, through our algorithms and through our little triggers that pop up, who's been vaccinated, who needs to be vaccinated. We're able to have conversations with members related to their concerns, related to their question, and then leverage the power of our relationship with our members to get somebody signed up for a vaccination. I wanted to let you know about a terrific toolkit coming out of Kaiser Permanente nationally related to vaccine confidence. You can just use your favorite web browser and type Kaiser Permanente vaccine confidence, and you'll see this great about 60-page toolkit that really has a few pages that are really terrific relating to understanding kind of consumer or healthcare user patterns of vaccine confidence for vaccine resistance, and really how to target the best way to communicate to these individuals depending on where they are in their spectrum of vaccine confidence versus not. The toolkit's targeted both for healthcare as well as for local governments. So I think it's excellent, and I would encourage people to take a look at that, or let Sapari know. We're happy to forward you the PDF. As you all know, the Oregon Convention Center, All for Oregon, closed about a month ago after delivering 550,000 vaccines. In terms of current disease activity, our 7-day rolling average of cases in our healthcare system is just 30, which is on the lower side of things at the 3.5% positivity rate, also on the lower side of things. However, if you do look carefully at the data, you'll see over the last 3 to 4 weeks, we can see those numbers have been increasing. Our current inpatient census is 18. This is also on the lower end of where things have been for the last year and a half, but also increased over 2 weeks ago. Again, that data is very consistent with Oregon statewide data and national data. So that's the lay of the land from the clinical perspective at Kaiser Permanente. I think Sapari has a few additional comments.
I do. Thank you. Just wanted to give a quick update in support of the national effort to vaccinate 70% of the population by July 4th. We actually launched a sweepstake to boost the vaccination rates. It was available to all KP members 12 and older, and also non-members who receive vaccinations in our KP facilities. And members needed to get their first dose at least by July 9th to be eligible. And the prizes include wellness retreats, healthy meal delivery, and gym memberships. So after we launched that sweepstake, we did see a small spike shortly afterwards. However, when we're looking at the data now, it is steadily declining. And also wanted to give you a quick update on our benefits for COVID-related issues. So just a reminder that our national benefit policy to waive member out-of-pocket costs for treatment related to positive COVID diagnosis will end at the end of this month, so on July 31st. Our COVID treatment will still be covered. However, it will be covered according to the member's benefit plan, as we covered any other medical treatments. And also wanted to share that we will continue to follow federal regulations that require no out-of-pocket cost sharing for COVID testing for members through the end of the national public health emergency period, which I understand, I recently just heard this morning actually that the national public health emergency has been extended to October 18th of 2021. And by policy, we will extend that coverage to the last day of the month following the end of the national public health emergency. So that means at the end of October 31st is when the cost sharing will be adjusted. That's all of our updates. Do you have any questions for us? Okay, thank you.
Thank you. All right, Providence is next.
Hi, good morning. This is Cash. Can you hear me okay?
Yes, volume's good. Good to see you.
Good. Awesome. Well, good morning, everyone. Cash Spencer with Providence Health Plan. With me today, I have Helen Noon Harnsberger, who's our Vice President of our pharmacy team, and also Jessica Nikulcha, who is a specialist, a clinical pharmacy specialist on our pharmacy team. So they'll give a quick update on our vaccination status, and then I'll close it up with just some additional comments.
Thank you, Cash. This is Jessica Nikulcha. So I just wanted to first apologize because I couldn't get my camera to work, but let's get into PEBB's member vaccination for COVID-19. So as of this past Friday, on 7/16/2021, PEBB has 65.7%, or approximately 51,600 members that are 12 years of age and older that are partially or fully vaccinated against COVID-19. And partially or fully vaccinated means that individuals have received either one shot of their Moderna or Pfizer vaccine or have completed the complete two-shot series of the Moderna or Pfizer vaccine or the complete one-shot series of the Johnson & Johnson vaccine. 62.4% of PEB members have fully completed their vaccine series, and that is approximately 49,000 members. When we look at total population, so this includes even the ages that aren't eligible for the COVID-19 vaccine, so younger than 12 years of age, we can see that PEB's total membership of fully vaccinated members is very similar to that of Oregon's percentage of fully vaccinated residents, with PEB being 53.6% fully vaccinated and Oregon residents being 53.2% fully vaccinated. And this is higher than the United States national percentage of 48.3% of individuals who are fully vaccinated as well. In addition to the overall vaccination rate, we also have additional vaccination rate by age. So just as another review, partially and fully vaccinated for PEB overall is 65.7%. And we can see that the age ranges that have higher percentages for COVID-19 vaccinations are ages 41 and up, with ages 41 to 64 being 73.7% partially and fully vaccinated, ages 65 to 79 being 83.8%, and with the highest vaccination being ages 80 and over at 85.4%, as this population was the population that first received eligibility for the COVID-19 vaccinations. The younger age groups are, so ages 12 through age 40 is the age group that has slightly lower vaccination rates. And this is the age groups that weren't eligible as early on as some of those later on age groups. So ages 12 to 15 is 47.2% partially and fully vaccinated. Ages 16 to 17 is 54%. And age 18 to 40 is 57.9%. We also have additional information stratified for COVID-19 vaccination by race. And this information I know that we did present in May, of which we did see an increase in every single community or race that I will be mentioning. And that was an over a 10% increase in vaccination, 10% or over since May. So in the Asian population, in May, we had 71.4% partially or fully vaccinated, and we're now seeing 85.4%. In the Black subcategory, in May, we had 53.9%. We're now at 70%. In the Hispanic group, we see in May it was 52.5%. It's now 67.2%. In our white population, we saw 56.1% in May. It's now at 66.6%. Native Hawaiian Pacific Islander was at 49.1%. It is now at 63%. In our unknown category, so individuals who did not state their race, in May, it was at 51.4%. It's now at 61.8%. And then finally, in the American Indian, Alaskan Native, in May it was 45.5%, and now it is at 57.7%. So we have seen an increase in every single race, which is wonderful. But as you know, there is still more work to be done in various populations. Now I'm going to hand it off to Helen Noon and Harnsberger to speak about some of our communications and also future outreaches that we have planned.
Can I interject a question just to clarify here? Were those numbers that you were giving just now, were those statewide numbers or were those Providence specific numbers or Providence members?
That is overall for PEB for statewide and choice.
Okay, got you. Okay, thank you.
Mm-hmm.
Yeah. So Sean and board members, we're going to be sending you really the slide deck for this so that you can look at it. I think those were a lot of numbers to present to you all, but we knew that you didn't really want a slide presentation. So we're going to send the numbers to you so that you have them. But we have made great strides over the last month, especially working in with to decrease disparities. That work has really been led by our health system through our community outreach efforts across the metro area in pretty much every area that had zip codes that had low vaccination rates. So we are able to go down to the zip code level to see where we have pockets of individuals, which obviously includes PEBB members that need vaccination. And so that was the way that the strategy was used to identify the communities that we put mini clinics in. So I just want to give you then a brief update on kind of our path forward looking toward the future, because as you all know, and as we just keep hearing over and over again, we're not through this pandemic. We still have a lot of individuals in America who aren't vaccinated, including those who are eligible for vaccination. So that's a concern as we head into fall and winter, and a concern especially in those pockets of counties and zip codes that have a high non-vaccinated rate for whatever reason, if it's related to health equity issue, if it's related to health literacy issue, if it's related to just not having the right information. So our path forward has been to continue to make sure we have updated information on our website available for our members as well as our internal staff who are continuing to, in our call centers, be able to have conversations with members who aren't vaccinated and be able to offer, again, options for vaccination. And then our care managers are focused on those individuals who are in high-risk groups from a disease perspective, focusing, it's generally 40 and above, but people who have chronic complex conditions who still haven't vaccinated. So those calls, both on an inbound basis and an outbound basis, are continuing, as well as through our medication therapy management program. And that does include our PEBB members that we're reaching out to. In addition, we are sending postcards and emails to those who are identified as non-vaccinators. It's actually going, if there's a home where there's at least one person that's age eligible, we are sending those emails and postcards to that home. So it's not identifying the person that's non-vaccinated, but sending a general message about vaccination. And we're really focusing on the fact that physician groups have access to vaccine now. Virtually all of our PCPs are administering vaccination directly through their clinics. I know some of them worked throughout the month of June to get their workflows finalized and incorporated into their work so that they could be vaccinating. And that can include, even if it's just one patient who they encounter in a day that needs vaccination, they will vaccinate that one person. As you know, probably the state immunization program did relax its wastage rules with really the hope of assuring that we're not just trying to wait until we've got 5 or 10 people available in a span of 6 hours to vaccinate, but rather to make sure that we vaccinate everyone who presents and will accept a vaccine in their clinics. So that's been a big help to physician offices in particular. Especially in our rural areas. So we've really focused on the fact that physician and pharmacy partners are readily available. Many pharmacies and even some physician offices will see patients for vaccines without an appointment. And community clinics are continuing in the locales that people live in. So we're directing people to look for those opportunities. Looking forward to the fall, we've been in contact with Husan, who is responsible for the flu vaccination through getaflushot.com. They're planning to do COVID-19 vaccine, offer that in addition to flu vaccine this season. But even before that, if PEBB is interested in doing additional employer group vaccination clinics with employees and possibly family members, depending on your policies with your agencies and desire to do so, we are ready and able to make sure that we have a pharmacy provider or work directly with Husan first if you prefer to get those vaccination clinics scheduled. As you know, we made that offer in May. We did get one clinic up in Klamath Falls at OIT, and it was really put together very quickly, and it went well. We were able to use providers from the Klamath Falls community, from the local Albertsons in that community, and they came up to OIT and provided the vaccine. I think the staff on site at OIT, at least they articulated that they thought it went very well. They wish they had taken a little more time with planning, but they were up against the end of the school year and wanted to capture both staff and students who were on the campus. And so it really ramped up pretty quickly. But I think those are examples of things that I think we can partner with PEBB to the extent you wish, and make sure that those vaccination clinics are put in place at locations that are meaningful across the state for your employees. And we have had a lot of success with that with our employer groups, and some of the employer groups have also opted to include family members, invite them to participate either in certain hours of the vaccination day or throughout the day. So that can be done that way. We've also done them inside and outside, so they can be set up with a tent on the outside of the building where your employees work. So there's lots of ways to do it to make it safe, especially as we move to fall. And I think people are realizing that we need to still, protect ourselves and protect each other. And it won't surprise me if we're doing some more masking as we move into fall. I know a lot of people are voluntarily doing that. So with that, I'll just leave it open to any questions that you might have for Cash, myself, or Jessica.
Yeah, I quickly just want to close with kind of reiterating what Helen just said. So at the conclusion of this meeting today, I'll send to Rose and Ali the slides that Jessica reviewed so that you'll have the actual stats that she presented so you can kind of see them face to face. Kind of going back to the question that was asked earlier when Moda was presenting, over 40% of our data comes from the alert system. So we have been collecting that, and it is included in the vaccination information that we presented today. And also, as Helen pointed out, we are out at a lot of these community events, which does not always include an opportunity to collect insurance information. So some of the reported rates may be underreported just simply for the fact that we don't necessarily collect all information, and there's also a lag in when people or those providers actually report out to us. And then finally, some of these resources, all of the things that we're doing to keep people updated beyond just what Helen pointed out as far as our mailers, our communications, we do have on our PEBB microsite, so providencehealthplan.com/PEBB. There's information in our banner there. And then also coronavirus.providence.org, there's information there. So with that, any questions you have for Providence?
Any questions?
This is Mark. I just wanted to ask if there are people who get either tested or vaccinated and they do incur costs, they can simply apply for a reimbursement from Providence, correct?
That is correct.
Yes, that's true. And we do reach out to those providers and remind them that by law, they're required not to charge for that vaccination. That's a condition of being a participating person giving COVID vaccine. So thanks for that question.
So just following up on what Mark asked, how long are you continuing to cover treatment? Is it the same as Kaiser through the end of October? And I know we voted on different measures, so I don't remember where we are with Providence.
Yeah, great question, Shaban. Actually, PEB determines how far we go, so we follow PEB's direction. The last vote that the board had was to go to the end of the public emergency period, and we're continuing to follow that direction. So until PEB tells us to go back to charging cost shares, we're continuing to not charge cost shares because PEB has not told us to do so yet.
Thank you. I thought we had that discussion. So it's through the end of October then. So it lines up with Kaiser, and the same would be true for MODA self-insured. I see you nodding your head,
Correct.
Ollie, on that. Okay, that's super helpful. And I appreciate hearing all the information about the clinics in communities. It sounds like that has helped drive up the vaccination rates.
Yeah, we did a lot of targeted outreach, as Helen pointed out, directly with our delivery system. I know I personally volunteered at some vaccination clinics in BIPOC communities, in immigrant communities, and some of those underrepresented communities to target those areas and increase vaccination rates in some of those under-vaccinated populations. So yes, we've been very, very involved in the community clinics.
I don't know if it's a question, but it's kind of towards everyone, and people can just kind of not respond if you like, because I understand that. But what I'm wondering about is, unfortunately, the vaccination rates are at this point being heavily influenced from political reasons. I don't want to overstate that. I mean, there's a lot being said about that, and I think it's true. But there's also like a diversity of reasons why different groups are lack confidence in vaccines. So I don't want to just like paint the entire brush. But I do think it's not that controversial to say that for some groups, some areas, some zip codes, there's like there's a political component here, and it's no longer a discussion purely about medical decisions. And I'm just wondering, again, not this can just be a wonder, and no one needs to respond, but I'm just wondering, these sort of large medical systems and their political teams, if there's any strategy or thought about kind of attempting to lower the temperature on any of that to allow the medical discussion to come back to the forefront in some of our communities. So that's just curiosity, because it feels like you know, the elephant in the room, and it's like we're doing all this good work related to like community outreach and so on, but at the same time we're like sailing into a storm. So it's like, how do we address that? And I don't know if there's a good answer.
This is Cash with Providence, and I'm not going to answer that question, but I will just comment based on the experience that I've seen within Providence. Our delivery system and our health plan, we've determined that the best course of action is to go where the need is, regardless of what the climate is of that community. So if there is a need to be vaccinated in that community, we're going to go there. We're going to find vaccinators in that area, and we're going to set up shop and try to get as many people vaccinated. For us, that's the bigger need, rather than trying to overcome political stuff that we can't really influence. We can certainly try to steer clear, or help re-educate people with, as it relates to misinformation, or stuff that they might see on the internet or online, and try to re-educate people. But as far as the political component of it, we really try to steer clear and just go to where the need is.
And I think, Cash, that's exactly right. And I think as I, Jessica, and Cash have done a lot of clinics during the past 6 or 8 months, there are so many other reasons people haven't vaccinated still, including people who don't want to vaccinate because the vaccines aren't FDA approved. There's also ambivalence and just, hey, it's not a concern to me. I'm really young. This disease doesn't really make me very sick if I happen to get it. So there is ambivalence in the 18 to 40-year-olds, and especially those who think of themselves as very healthy. But I think as time goes on, and in those communities where there are high percentages of non-vaccinated, there will be outbreaks, and those outbreaks will create opportunities because there will be families that will be hit hard by COVID in the next 6 months. I mean, that's what I think. And I know a lot of people in rural Oregon. I was born and raised in rural Oregon. I have been really working, especially in Klamath County, actually, because I have a lot of close relatives and friends in that community. And it is a lot of conversation and just being open to hear their opinion. And so if you can find willing participants who are connected with that community, and that's been true in all of our community vaccinations, even in the Portland metro area, that people in the communities who have connections with those people are the best way to get groups of those individuals together. It can be churches, it can be community centers, it can be schools, and basically places where people gather naturally as families and groups. And those are the kinds of opportunities that we still need to look for, all of us. And I think that all of your partners here are committed to that. But I do know that we are sincere in our desire to make sure that we get our numbers even higher for our PEBB membership, and we will go. We will go to the Wallowas. We will go where we're needed, and we will find vaccinators that can be there when you need them, anywhere in Eastern Oregon, Southern Oregon, and I think it's a community effort. So we can work with your agency heads and your department managers and your people, because your people know people, and that can have a really strong influence on others to get vaccinated.
That's helpful. Thank you.
And Sean, I just wanted to, I'm not sure if we're going to talk about this now, Ollie, or a little later, but I do think the offer around the employer clinics is really important, and we should look at the dates when PEBB folks are going back to work. And I know September 1st is a big date. And then, of course, some of the universities a little later when students come back, although they have a vaccination mandate, so it'll look a little different there. And then also we have work sites that everyone's there now, right? Like all the DMVs. So I think any partnership around how we can get the vaccinations higher, we can look at those dates when we know more people will be in work sites.
Yeah, I think there's a lot of opportunity once people start getting back in the office. Like you said, or at September 1st is when agencies technically reopen to the public. We've reached out to all the universities and all the prisons in the state and offered to set up vaccination clinics, and only one took us up on the offer, which was OIT, as Providence just mentioned. But the others had already set up clinics through other channels. But I do think there's another opportunity with flu shot clinics coming up. And, we'll definitely explore that, because that would be really handy. I assume it would be okay to get vaccinated with a flu shot and a COVID-19 shot at the same time, but we'll definitely pursue that through our vendor. And then I just wanted to give a quick update on our Vaccination Incentive program. So we rolled that out in the last week in June, and the first day we actually had 10,000 employees submit for the $100 incentive. And since then we're at 20,000. So half of those were on the first day, and that's about 40% of the eligible employees. So the program is set to expire at the end of this month. We have another communication going out at the end of this week, and we'll really be putting the message out as the month concludes. And we continue to be concerned about the low rate of vaccinations and continue to look at ways we can increase that percentage. And I know from the federal level, they're really hoping to get vaccinations through primary care. That people trust maybe a little bit more than going to a vaccination clinic and follow doctor's orders. But feel free to always, if you have any great ideas, to contact us, and there are creative ways of getting those percentages up, I hope.
So, Ollie, I just had a couple of questions because I know your staff and the board leadership are empowered to make decisions around the incentive. And I'm just curious about thoughts on whether we should extend it for another month, just to help drive up rates. I know Kaiser just reported a small bump when they had their sweepstakes, and I'm pretty sure, and you probably know this, Sean and others on the call, but I thought we had a bump when the governor did the same for the state of Oregon, and that just incentives may give us a small bump for those who are hesitant, and whether that's worth extending for another month, especially if we're going to try to do any clinics with folks coming back to work.
Mm-hmm. Yeah, I spoke to staff about that, and we can do that. We can extend it another month. I think anything that would potentially increase that percentage, even as small as it may be, would be tremendous benefit to the state as a whole. So we can work with board leadership and if other board members are supportive of that, and look to do that.
Yeah, I mean, I think it's worth discussing. I mean, I think that's worth considering seriously. I mean, at this point in the state, we're fighting over a dozen people, just day by day. Anything we can do. I think our general, week over week increase is like 0.9% or so, something to this effect. So it's like, anything we can do to add a few people at this point, that's kind of where we're at. It's just, clawing our way through these small percent increases,
Agreed. And Mercer will have their utilization dashboard report next, and they'll have some more PEBB-wide numbers, and we can look a little bit more targeted regionally about what's going on and have a little bit broader discussion. Thank you.
Thanks. Okay, let's move on. Mark Perlman, did you join us?
Yes, I'm here.
Okay, so I think we can go back and do minutes from our last meeting if people have had a chance to review them. I'm willing to entertain a motion.
This is Siobhan. I reviewed the minutes, and I will make a motion that we approve the May board minutes.
Okay.
This is Mark. I'll second.
All right. Motion and second. Any discussion, clarifications on the notes? Okay. With that, Kim Harmon, how do you vote?
Yes.
And Kate Ness?
Yes.
Mark?
Yes.
Siobhan?
Yes.
Did I miss anyone on the board? No. Okay. Motion carries. Thank you. So back to the agenda then. I think we are on to the utilization report.
Good morning, everyone. Rose, would you like me to share my screen?
Yeah, sure, Nick, go ahead. I'll get off.
Okay, perfect. Okay. All right, so everyone should be able to see that. So we will spend a little bit of time this morning talking about the latest utilization report. So as Ollie mentioned, we do have some COVID-19 updates and impact. What we do is kind of consolidate a lot of the data that was shared by your carriers into one, concise section in our report. We then have our kind of standard reporting as far as, what happened in 2020 versus 2019 and 2018 as far as aggregate costs, the various trend components. We also have our clinical analysis. We have a low value care section looking at some of the stuff we looked at 6 months ago regarding low value services. And then what we have identified as the top opportunities and next steps. So with that, I just want to spend a few minutes talking about the data that we're using for this report. So we do have full calendar years in this report. So we have full year 2020 compared to 2019 and then compared to 2018. So we do look at 3 years. The plans, most of the plans are obviously self-insured now. The only plans that we look at that are fully insured are the Kaiser plans in this report. In the caveats section of this, we do want to point out that in some of the slides that we show, there are additional fees that we report for Kaiser, and these are the integrated care fees. You can see the dollar amounts for those fees. They're per member costs for essentially non-claim services. Essentially, you could think of them almost as capitation payments. In most of the reporting, we don't include those just because it's not reported within the data warehouse. But I'll point out the slides where we do add those costs in. The last bullet on this slide, we did learn a few weeks ago that in some instances for only double covered members, Kaiser's reported charges for the allowed amounts are slightly overstated. We have corrected this issue going forward, but as of when we pulled all the data for this report, that issue had not been corrected within the data warehouse and Kaiser. So I just want to call that out. It's not a very big impact. I think anywhere from 1% to 2% for those affected members, and it only affects double covered members. I just wanted to point that out for the board and everyone on the call here. Okay, so our first section related to COVID-19. So this is showing information from one of our sister company, Oliver Wyman. They have a tool called the Pandemic Navigator. The left-hand side of the page, starting with that chart, is the case counts. So basically the prevalence of cases within the state of Oregon. The blue line is the confirmed cases. The black line at the bottom is the estimated active cases. And then the sort of orange, light orange and dark orange are the new cases. So as you can see, the new case 7-day average, if you look over at this area, sort of in this July, we pulled this data on July 14th. It is trending upward, as all the carriers discussed. The Delta variant is significant and taking hold. Oops. Am I still? Yeah, I'm still sharing my screen. So that has increased the cases. When I was looking at this 2 weeks ago, a lot of these maps, so these heat maps for both the United States and Oregon, were all a much lighter shade of red. You can see that for most of the country now, we have weekly changes in cases greater than 50%. Compared to the prior week. And so Oregon, you can see, is a slightly less dark red, but that is not off by too much. So if you look down here, Oregon actually had a 49.8% weekly change in cases. And again, this is across Oregon, not just PEBB specific. In most counties, as you can see, we did discuss rural counties in particular, but quite frankly, even some of the urban counties are seeing high case rate growth, and I think Helen talked about that as far as just reluctance from certain groups, age ranges, groups of people from getting the vaccine. All that said, Oregon is still below national average as far as total number of confirmed cases, about a third of the national average, but the growth rate is concerning. Talking a little bit about PEBB specific COVID-19 impacts. So the top half of this slide gives some high level information about testing, prevalence rates, treatment costs, deferred care, all of that stuff. So the first number, 46,000. So that's the number of members tested within the self-insured plan. So we're talking about choice, statewide, and MOTA. 7.1% positive test rate. So out of all of those tests, 7.1% have returned a positive test rate. That has increased. So if you pulled up our utilization report from last time, that was at, I believe, 3.1%. So the positive test rate has increased, but my personal opinion is it's actually more of a function of less tests being administered and taken overall. And the people that are getting tests are typically showing signs, they need to go get tested. And so that has ticked up a little bit. So it's still less than national average as far as a positive test rate is concerned. The 2.1%, so that's of those, positive tests, 2.1% were admitted to the hospital. That is below where we would expect PEBB to be based on just demographics, age ranges within the population. So overall, it's good news on that front. And then testing and treatment costs are that $9.6 million spend for PEBB. So obviously the deferred care and the claims that were put off in 2020 far outpaced the testing and treatment costs, but that's through May 2021. And then that right-hand number, that $121 million, so that is the result of delayed or deferred care. So that is basically the growth in surplus that we experienced in 2020 and year-to-date in 2021. And just jumping down then to that bar chart in the bottom right-hand part of the page here, you can see that, care increased or the cost of care increased on a per employee basis towards the end of 2020. So we did see an uptick in claims. But then starting in the new plan year, so January, February, and March, both saw, lower than budget, lower than expected budget costs for medical care. That has changed in April and May. So in May, claims were about 61 million. April was about 65 million. The only reason that May bar is bigger than April was actually because April was a pharmacy rebate month. So it was actually the costs were offset by pharmacy rebates that we received from both Providence and MOTA. So otherwise, though, both months were over expected budget. So the care and the costs have returned. The left-hand side, and we've spent a bit of time talking about the vaccination rates, you can see that what we've tried to do is break out the fully vaccinated portion of the population compared to the people that are partially vaccinated for both choice, statewide, MOTA, and Kaiser at the bottom. MOTA, you can tell is lagging as far as just reported vaccination rates. But again, as Erica mentioned, getting that alert data will drive that up significantly. So once MOTA has that, they will be able to better report and update the board on how many members are actually vaccinated, because as you can see, it is lagging compared to the other carriers. And I believe Cash mentioned that they have been getting the alert data. So choice and statewide are as accurate as we can. Across all the carriers, though, we know that the vaccination rates are being underreported just because oftentimes at the mass vaccination clinics, they have not asked for insurance cards. So this is likely slightly underreported. Any questions on the sort of the financial components or the vaccination rates or anything on this slide? Okay.
Well,
okay, so go ahead, Sean. Yeah.
So just a technical question here. So I think we have a pretty good overview of who all has been vaccinated or how many people have been vaccinated in the state of Oregon at a state level, due to the fact that the alert database is relatively complete. I think it's missing veteran, VA, federal facilities, that kind of thing. But for the most part, fairly complete. And I'm understanding that some of the carriers are able to draw some of that information out of alert. So my technical question is, when they do that, like, let's say that I can't remember right now if alert has information one way or the other about insurance. I kind of think it doesn't. But in any case, like, are they looking for names and essentially matching them? Is that what's happening?
I believe that's how the process works.
Okay.
Yeah. Yeah. Names and date of birth, basically any identifiable information compared to their member database. Yeah.
Got it. Okay. Thanks.
Yep.
And that was why MOTA, because MOTA hasn't done the match yet to the alert system, their numbers are really low.
Exactly. Yeah.
Okay. And then didn't Kaiser report higher numbers than the 56.8? I thought they did.
Yeah, and Sapari and Dr. Bachman likely were referring to their reporting as the split between subscribers and dependents. So if you look at like the choice numbers, for instance, a higher percentage of your subscribers, so your PEBB employees, are vaccinated, but that falls when you talk about dependents, just because children under the age of 12, for instance, are not even eligible for the vaccine. So Kaiser were reporting in aggregate. That's just because their reports provide that in aggregate, but you very well could be correct, Siobhan, that the subscriber count for Kaiser is higher than that for vaccinations.
Okay. This is Sapari, Nick. That's accurate. Yes, our subscriber counts are much higher.
Great.
And Sapari, is there a difference there because Kaiser just has a higher number of dependents that can't yet get vaccinated? Because I know you had said Kaiser PEB members were doing as well as other as other Kaiser members. Is that correct?
Correct. Yeah, when we looked at total subscriber counts as compared to dependent counts in comparison to our book of business, it is very similar. Is that your question, Siobhan?
No, so when I was looking at the Kaiser rates here seem to be lower. The 56.8% is lower than the subscribers at PEB, and I guess I was just asking if that was partially skewed because there are more dependents that aren't eligible for vaccination.
I would say use our data as the most up-to-date data. It's coming from the statewide system. So this may be just a few weeks old. So I suspect next time this is run, you'll see a higher number.
Got it. Thank you.
And we just pulled this data a couple of days ago, so it's a bit more current.
Yep. Siobhan, just for, I guess you and the board's kind of orienting yourself. So if we look at like choice, for instance, PEB on average has, let's just call it two dependents for each subscriber. And so if you do the weighted average, weighting, 69.9% of subscribers as one, and then 52.9 as two, you sort of get this weighted average that is much closer than, or much closer to Kaiser's overall vaccination rate. So it aligns. It's just a slightly different way to report it.
Okay, thank you.
Yeah. So let's talk a little bit about the screening. So this is of importance, obviously, as we talk about what the long-term effects of COVID may be from a total population health perspective. The top left graph is screening rate for various forms of cancer. So we have cervical cancer, mammogram screening rates, colon cancer, and then PSA, which is prostate cancer. The screening rates all obviously dipped in that March, April, May timeframe. They have since returned to normal, relatively normal levels, but the damage, so to speak, has been done. What we would hope and what we can continue to monitor into 2021 is to see if those screening rates have increased compared to prior years. So maybe there's a catch-up effect. This slide does get into February 2021 data, as you can see. So we did pull information as recent as the database has available to us. You can see that screening rates returned to basically prior levels, but maybe the hope would be that they actually increased slightly. So we'll continue to monitor that. The other three relate to newly diagnosed patients for those various chronic conditions. The blue is 2019, 2020 data, and then the red are 2020 and 2021 data. And then that black line that superimposes the graph is the percent change between the 2 years. So the black line corresponds to the right axis. The bar charts correspond to the left axis. You can see that newly diagnosed patients across all three of those conditions are less than the prior year. And what that downstream effect has is, I'm guessing, there is not all of a sudden a lower prevalence of diabetes in PEB's population. So what does that mean if we have less newly diagnosed diabetics? Well, it likely means maybe they're being undiagnosed from a clinical perspective. And so if a member is undiagnosed, obviously that has effects on their overall care and their health. If we don't catch some of these diseases and treat them early rather than later. And so you can actually see some of this information is reflected later in our presentation regarding the risk scores. So the risk scores dropped across PEB as well, and that likely has a result or is a result of some of these chronic conditions being underreported as far as newly diagnosed patients.
That this is Sean. Yeah, that is an important discussion we should continue to pursue, because from what information we're just starting to get in public health data, it is looking like there was a sort of an average increase in body weight among Americans in general. And I don't know, I don't think it's known yet, like how many pounds, but there's a lot of people, as you know, that are pre-diabetic. They're right on the border, and those few pounds matter. Plus it's an average. As far as metabolic health, being sort of the tipping point into diagnosable diabetes, is right around there. So given that data, you would expect the diabetes rate to be higher. And if we're detecting it's lower, that to me, that's fairly clear that means we are currently in a phase of underdiagnosing people with diabetes, and thus, probably also hypertension for same reason. So that's a concern, because it's not helpful to look like you're healthier when you actually aren't, from the point of view of managing health costs. The other question I had about the screening rates, I'm assuming the way that this chart is, it's like this is the rate per month of people screened. Is there any, this is a tough question, but is there any possibility of us being able to get a population view of percent of people currently screened? So, I mean, that's kind of complicated. Like, for example, with colorectal cancer screening, you got to combine a bunch of, it's like how many people are of the right age.
Yeah.
And then how many of them had an FOBT or whatever in this year, or a sigmoidoscopy in 5 years, or a colonoscopy in 10, that's a tough number. But that's kind of what we're getting at is, did we catch that dip, the people that missed, maybe they missed a year or they were late, but now they're back? Or is this a permanent divot in the overall number of people screened that we're going to be crawling out of for some time? Like we're trying to catch up. That to me is the big question. And I don't know if we're going to find out just from the month to month rate of people being screened, if that makes sense.
That does make sense. I think one thing that we have within the database, I immediately, when you said that, Sean, thought about like gaps in care, and maybe not gaps in care from, okay, this member needs to take this medication, but this member is not taking this medication. Gaps in care in terms of, you know, to your point, I am in this age range. I am a female. I need to get a mammogram, for instance. And that's something maybe we can tease out. I will look into that. I think that's a good question, though.
Hey, I just have a follow-up question just around concern that there are a lot of people who are not getting diagnosed. And, you know, I know the focus is on COVID around clinics, but is there a way to, if we do employer clinics, can we also do diabetes screenings and, you know, take people's blood pressure so that there can be a screen for some other things as an option when that happens? I'm curious about that all day, but just, you know, the worry that.
Yeah, you know, it's interesting. PEBB used to have a health clinic down across the Capitol on Court Street, and they could do all those things, had a nurse practitioner on site there. And unfortunately, it was defunded by the legislature, I think, in 2006. But that, you know, is something, you know, that added a lot of value, and, you know, the board could potentially look at. I don't know about setting up clinics to do those things, but we'll definitely, we'll look at that.
Okay. Okay, so this slide again looks at preventive screening rates. What this does is sort of aggregate the monthly data that we just went over into the years that we're looking at. So left to right, 2018, 2019, and 2020. And then that gray column on the far right is Mercer Book of Business screening rates. So the first section is employee preventive visits. Then we have the spouse preventive visits, and then we have some of the screening rates that we talked about on the last slide: breast cancer, cervical, cholesterol screening rates, and then colon cancer screening rates. So as you can see, that, you know, not entirely unexpected. The dark blue is a drop compared to the prior years. But I think, you know, I think, Sean, to your point, I think this is not entirely unexpected, right? The question is, will it catch up in 2021 as we hopefully emerge out of the pandemic and people are more comfortable returning to in-person services? So that's something we can look at with you know, with our data to continue to monitor. Let's spend a little bit of time talking about telemedicine. So this is telemedicine visits per 1,000 members. And these next two slides. So this slide is Kaiser HMO, Kaiser deductible. The next slide is MOTA Providence and statewide. What we have here are the blue portion of these bar graphs are mental health, substance abuse related claims for telemedicine. The purple portion are everything else. So you can see both Kaiser plans already had a good usage and prevalence of telemedicine visits prior to the pandemic. That has since increased dramatically. Kaiser, you know, obviously has had always a strong culture with e-visits and whatnot. So not entirely unexpected that you know, even though Kaiser had a good history of having utilization with telemedicine, increasing that during the pandemic. Moving over to the self-funded plans, this is where we saw the dramatic increase in telemedicine visits. You can see that the bar charts for most of these plans do not even show up prior to March of 2020. And I just want to again point out that these include community providers. So these charts include providers who are normally in person in the community, who shifted their modality of delivering care to telemedicine services. So both, you know, for both MOTA and Providence Choice and statewide, we saw a drastic increase in claims related to telemedicine. Mental health and substance abuse claims were, you know, not unsurprisingly up up significantly, likely as a result of the pandemic related stressors. We had a lot of social unrest, obviously, and we continue to have social unrest. So there's a lot of confluence of different events happening in folks' lives that cause an increase in mental health related telemedicine visits and claims. What we want to do is continue to look at this telemedicine, as we progress into 2021, because one of the questions we have not only for PEBB, but across, one of these big theoretical questions is, are telemedicine visits, an acceptable form of care for most members, as far as, okay, because we know the screening rates, for instance, are down. Well, a lot of times when you go to an in-person visit for a provider, you can walk next door and get your lab work done, for instance. You can't do that with a telemedicine visit. So are these members who are going to telehealth providers or telemedicine providers virtually, are they following up and getting the needed lab work done or the needed diagnostic testing done that their provider is telling them to go get if they need it done? And likely it's a lot harder for us to get out of our offices at home after talking with our doctor and actually drive somewhere than it is, again, you're already in the facility. So what we want to explore is just continued monitoring of these telemedicine visits in relation to in-person visits. Yeah, go ahead.
That was going to be my exact question. So thank you for just hitting the nail on the head there, because that's the main question. I think there's a lot of potential, of course, for telemedicine, but it's all about just combining those two conversations about the screening versus this. So maybe to put a little more fine point on it, one of the questions that I would be interested in knowing, and I'm sure that this is going to be different, I guess, for the different carriers, but to what degree and like how do they integrate telemedicine into their medical homes, into their system? Like, I think that some of the carriers, at least at some point, if not now, I mean, this is a question, I guess, they were contracting out the telemedicine. It's a different company, and thus, it's a vendor, as opposed to like this is part of a patient-centered primary care home. Like the person calling you literally is in the patient-centered primary care home. They belong, they're one of their patients. That's different. Those are two very different telemedicine experiences right there. And I would be curious what the mix of that is and what is the plan? What's the grand scheme as far as making sure that that telemedicine experience is as integrated as possible into their total care experience, just like you were saying, especially around, you come in, you have a sore throat. Also, they notice, oh, looks like you're pre-diabetic as well. Let's talk about that. And it looks like you haven't gotten your labs done in a while. Let's do that. That kind of integration, I think, is really important. And I would be curious to know more about what is the plan? How is it going now related to that with the different carriers?
Yeah, absolutely. One thing, Sean, to your point about the medical homes, the majority of these visits, I would say, and the carriers may be able to correct me, but the majority of these, 95%, I would say, are community providers. So we know that both MODA and Providence, and MODA offers Maru as a to your point, a standalone separate telemedicine vendor. Providence has their Providence Express virtual care, I believe. But the majority of these are actually the medical home providers offering virtual care. And so when that happens, the visit is obviously, part of the person's medical record within the medical home setting. But that's that's one thing that we always have when we're looking at telemedicine vendors that are standalone, is how does that interaction with that standalone get integrated into the rest of the members, visit history or health record. But I would say it's less of an issue for PEBB than it is for some of our clients who do have a lot of utilization through those standalone vendors.
I also just had a question on the telehealth overall. Actually, two different questions. One is around how much people are paying for it, because I did think we made some adjustments because of COVID around telehealth and access to telehealth. And I don't know if that's something too that we're going to have to look at after the end of October. And then the other piece on the data, I agree with what Sean's saying in terms of, you know, getting the information on what's integrated versus what isn't in the primary care center patient homes, but also, you know, the different types of care, because, you know, for example, with mental health care, do people have a lot more access to the kind of provider that they want to see? I know we talked about health equity and there being very few BIPOC providers. And is that something that's been expanded because of the expansion of telehealth? So I think those things are important to look at as well.
Right. And in September, the carriers will be looking at that further, Siobhan, to your point about access to BIPOC providers, and so yeah, has telemedicine enhanced their ability to offer different cultural competencies related to not only mental health but regular care as well. Yeah, so all important questions. I would say for the cost sharing, I believe carriers are all on, so they can correct me if I'm wrong, but the cost sharing is the same. So if you have a copay for primary care, if your provider offers a telemedicine visit, the same copay applies. On the back end, what we're finding in the data is that the reimbursement rates for telemedicine and in-office care are the same. Or relatively the same. So the plans, not just your PEBB plans, but nationally, again, plans are reimbursing these community providers who are offering telemedicine services at the same rate they would do in person. So that, again, goes back to our value conversation. What is the value of an in-person visit versus telemedicine, especially if the rates are the same, or if PEBB is getting charged the same rate for a telemedicine visit versus in person? Is there the same level of value? So I think that's important to look at as well. So last point on the COVID section is the emergency room visits. So overall, total ER usage went down 19.7% in 2020 compared to 2019. That is the blue part of this. So the blue part is the total ER visits, and that's the left-hand axis. The green line is the percentage of those that are classified as non-emergent visits to the ER. So that could be anything from body aches, ear infection, migraines, sore throat, that type of stuff, where after the fact, the algorithm basically looks and says, that probably wasn't warranted for an ER visit. So that actually decreased as well. So what we found in 2020 compared to 2019 is that non-emergent visits decreased from 22.6% down to 19.8% in 2020. Okay. So next section is 3 slides related to aggregate costs. So what these slides, and they're all laid out in similar fashion. So this is self-insured, the next slide is fully insured, and then we take a look at both combined all in PEBB. So this section is where we actually do include Kaiser's integrated care fees. So we do have Kaiser's integrated care fees in here. We do have pharmacy rebates included in here. So to the extent that your carriers are, Providence and Moda are passing back pharmacy rebates, we do include those within these numbers that we show on these slides. So overall, for the self-funded plans, costs were down 9.8%, driven by the medical decrease. You can see that prescription drug was still chugging along at an 11.1% increase year over year. In that middle part of the table, it's the per employee per year. So this is where we divide out by the number of employees that are listed down at the third part of the table. Prescription drug increased 10.1%, and then medical decreased again 12.9% year over year, 2020 compared to 2019. And we do have a few slides on the prescription drug trend in particular, so I'll hit on that when we get to those slides. For the fully insured plan, so this is the deductible plan through Kaiser and the HMO through Kaiser. Again, we've included their integrated care fees into these costs. Overall costs decreased 14.7%. You can see that medical dropped even more drastically than what we saw in the self-funded plan at negative 18%. Prescription drug increased less so than what we saw in the self-funded plan at 7.3%. So overall, the trend was lower on the 2 Kaiser plans than what we saw on the 3 self-funded plans. And then finally, total PEBB. So this is combining self-insured and fully insured. Overall cost between medical and prescription drug was down 9.9%. And I think before I move on, prescription drug within this section is just drugs administered on the PBM, so through the pharmacy component of the plan. We know that there are injectable medications administered in facilities and professional settings. Those costs for those drugs are actually included in the medical spend line. So I just want to call that out. Again, there's a lot of different categories for these, and sometimes even for me, it gets a little confusing on where a certain procedure, drug, or whatnot is allocated. But on this particular slide, prescription drug is simply drugs administered, including specialty drugs, through the medical or through the PBM. So I just want to call that out. Okay. All right, so let's look at trend components. So this section is always of keen interest to Mercer, the board, and the plan. So this is looking at total PMPM, so per member per month cost or per member per year cost, whatever you want to look at. So the total annual increase is the purple, is the blue, is the blue line for current year. So this is comparing 2020 compared to 2019. And then that purple bar is 2019 compared to 2018. So the total annual increase in the current year on a per member basis was negative 10.2%. You can see that utilization, member health risk, and cost share and leveraging was all decreased. Cost share leveraging actually increased a little bit. I want to take a look at the unit costs, though. So I think unit cost is always something that we're monitoring very closely. Within our reporting, and I think this is very important, within our reporting, unit cost includes basically 3 components. Reimbursement rates, so what are you paying contractually for a primary care visit, for an MRI, for an X-ray. But it also adds in the mix of services and the intensity of those services. So I think about it this way, those 3 components. So we're taking a look at all PEBB. Let's assume PEBB has 10 members, and in year 1, every member goes to see a primary care doctor. If that cost of that primary care visit increases from $100 to $110, we'll capture that in the unit cost. Okay, so that's one component. Let's instead look at and say maybe in year 2, instead of going to 10 primary care visits, all of those members decided they want to go to specialists instead. So what we're tracking then in year 1 is, on average, each member spent $100, or the plan spent $100 at a primary care doctor. But in year 2, it's $200 per visit because they all went to specialists instead of primary care doctors. So that's where that second component here, that mix of services aspect, comes in. So the mix changed from a lower cost care to a higher cost care. So that's unit cost also tracks that. And then finally, the last one, that intensity portion. So let's say all of them had a 15-minute visit, office visit, and that changed to a 30-minute office visit in year 2. Because they had to talk to their doctor about some other issues they're having, and likewise the doctor charged more. Or the easier way is think about inpatient stays. So the days increased. The average days per stay increased on the inpatient side. So unit cost within Mercer's reporting takes into account all 3 of those components. And I just wanted to spend a few minutes talking about that because I think it's important when we think about unit costs. Utilization, member health risk, and the leveraging are all relatively easy to monitor. utilization, number of visits, number of admissions, member health risk. We'll talk about that in a few slides. And then the leveraging piece is, on average with medical trend, if you don't raise deductibles or copays or coinsurance, PEBB is picking up a higher percentage of the overall costs compared to the prior year. So that's essentially that last category on here where it's cost share and leveraging. So unit cost is sort of that catch-all bucket that teases out a lot of the different things we talk about. But there's different components being included in that.
Hey, Nick, I appreciate you walking through that. I would think that the decreased member health risk and the decreased utilization would mean fewer complicated intensive visits. But
So,
maybe we don't know that, and I know the member health risk is probably wrong, like we just talked
Right.
about earlier.
Right.
However, we know that people aren't getting diagnosed. So my assumption would be they're not going in and utilization is down.
So I actually thought about that same issue, Siobhan, but I thought about it in the opposite way. So thinking about utilization being down, who are the people not utilizing care? It's likely people don't have any sort of, at least they don't think they have any sort of underlying condition, maybe lower risk members, members who are younger, healthier, maybe they don't want to go in to see their doctor and whatnot. So the people that are remaining on the plan actually receiving care and incurring utilization, so to speak, those people are likely having higher acuity than the members who are staying home and not receiving care. And so that's why I actually thought about it a little bit different. Unit cost actually makes sense that it would increase because it's basically the intensity of those visits on average is increasing. At least that's how I thought about it.
But and the bottom line is we don't know, right?
It's hard to tease out. Yeah. So let's talk a little bit about service categories. So same or similar information that we presented on the previous slide on that top part of this page. So inpatient. Now we break it down by inpatient, outpatient, physician, pharmacy, and then all other costs. And then on the bottom half of the slide, we talk about what are the biggest cost drivers by each of the different plans. So that's why that's where I want to talk about. So for both choice and statewide, we saw that the precision specialty drug. So these are specialty drugs on the pharmacy plan. For both choice and statewide, the PMPM increased, $9.51 per member for choice, and then $9.88 per member on statewide. For choice, there was basically the top three drugs that had the biggest impact on that was a drug called Stelara that treats Crohn's disease, and there were 5 new patients on choice. Dupixent, which is an asthma, eczema, and polyp treatment, that had 12 new patients. And then a drug called Skyrizi, which is plaque psoriasis, and that had 6 new patients. So those were sort of the 3 biggest drug movers on the choice plan. Statewide had similar. So Skyrizi was on there again, and again that was plaque psoriasis. But for statewide, 21 new patients taking Skyrizi. Stelara was on there, so that was the Crohn's disease treatment for statewide. That only had 1 new patient, but the cost for the existing membership on statewide for just that Stelara piece increased about $900,000. And then statewide did have one difference. So on that specialty drug spend, and it was a drug called Norditropin Flex Pro, and that drug is actually used to treat low growth hormones in children, and that had 19 patients. So all in all, between choice and statewide, what we saw was an increase in the number of patients, again, taking specialty drugs. The cost of those drugs stayed relatively the same, but again, you just have more and more patient volume within those, and that is something that we've been experiencing now for a number of years, and the plans are doing their best to manage it, but again, it's not uncommon across not only PEBB but a lot of companies are dealing with PBM cost increases on the specialty side. MODA. So MODA was kind of an interesting one. So what we found was that facility inpatient maternity costs had increased pretty dramatically, and actually later in the report we see that newborn costs actually rose to one of your top 5 clinical conditions. We looked at this, and what we normally find is when maternity or newborn costs increase dramatically, what we normally think about, well, okay, was there a NICU stay? Were there some high cost maternity? Again, related to was one of the dependents or babies in the hospital for a long time getting treatment? We didn't find any of that. So we actually had to reach out to our MODA team on the call here, and what they actually let us know was that for newborn costs, this was actually related to some of the rulemaking and some of the original rules imposed by Senate Bill 1067, which was the 200% of Medicare cap. So what happened was in 2020, MODA began paying claims at 200% of Medicare. Whereas before in 2019, those claims were being paid at just the billed amount. So what happened is that 200% of Medicare actually increased the reimbursement rates for some of their providers. And what we saw is specifically on the inpatient maternity and the newborn costs, it had a dramatic increase on MODA's PMPM. You can see that the costs increased close to 60% on a per member basis. That being said, this was corrected. So part of the rulemaking process that we went through towards the end of last year clarified that Senate Bill 1067, the plans should pay at the lesser of billed amount versus 200% of Medicare. So as of December 24th of 2020, MODA is paying now back at the lower billed amounts for those services, but in 2020 they were paying at that higher amount, and so that's really what the inpatient maternity was driven by on the MODA piece.
Thanks for covering that, Nick. And I believe MODA just finished reprocessing those claims, so
Perfect.
We're all done with that. Yeah.
Perfect. Thank you, Ollie. Yeah. So that was an anomaly. I just wanted to call that out and explain. So that's again, that's fixed, and it has been fixed moving forward, and will retroact, or MODA has fixed that.
So just to clarify, make sure I'm understanding correctly. So we're going to be getting some of our money back then?
So it was
retroactive?
Yeah, so it's my understanding that MODA is not retroactively processing claims, but Ollie or Erica, I know Erica's on the line, but maybe one could speak to those.
Yeah, and so the rules became effective December 2020, like Nick said, and they were implemented on a prospective basis, meaning that we were able to change the way we were paying the claims, but only prospectively. So those claims for 2020 are not able to be reprocessed.
So there were a lot of happy members, but it cost us money.
Well, yeah.
Yeah.
So the last two plans, so Kaiser Deductible and Kaiser HMO. So Kaiser Deductible, again, we see this inpatient cost come up, specifically related to the surgical components. And this actually was related to large claimants. So there was one claimant related to cancer, one claimant related to musculoskeletal that appeared on the Kaiser Deductible plan that drove up those inpatient surgical costs. For Kaiser HMO, it was physician non-specialty outpatient other. That is a handful to say. What we think is actually being bucketed in those costs are actually COVID related claims. So as we know, there were a lot of costs incurred by Kaiser to keep facilities running. They diverted a lot of their dental practice, not only staff, but resources. Since no one was receiving dental care, they diverted a lot of those resources into the medical setting to ensure that the medical setting was safe and available for members to be able to access. I think what's happening with that particular category is a lot of those costs incurred by Kaiser are being bucketed into this particular category. When we dove into the data more for that category, It did not get any clearer. There were a lot of missing sort of descriptions within the warehouse related to that category, and we actually think that's what's happening is a lot of their COVID related costs are being bucketed into that particular physician non-specialty outpatient category. Okay, just doing a time check. We have a little bit of time. So risk scores. So again, this is on the far right-hand side, this is that 6.7% or 7% decrease that I referenced earlier. So across all of PEBB, we're seeing a decrease in the risk scores driven by the HMO and statewide plans. But again, we likely know there's some missing element of that. I don't. It's my professional opinion that PEBB is not all of a sudden 7% healthier in 2020 compared to 2019. So there's likely some diagnosis issue that needs to catch up in 2021. And then finally in this section, the normalized cost by plan. So we do like to take a look at this, just comparing each of the plans' total paid claims and admin fees compared to their risk-adjusted costs. So the risk-adjusted cost is that purple line, and then the unadjusted paid claims and admin fees are in that blue and green bar chart. And this is another area where we do have Kaiser's integrated care fees included in that green portion of Kaiser's bar chart. One thing I want to note, this -4 for statewide is not an error. It is actually because we offset the admin fee for each of the self-insured carriers by pharmacy rebates. So MODA, Providence, and statewide, you're looking at their net administrative fee. So for the statewide plan, you actually receive more pharmacy rebates on a per member basis than you pay an admin fee. So that's why that -4 is there on the bar chart for the statewide plan. One thing I do want to call out, we don't often talk about large claimants a lot, but I figured this was an important place to talk about it in relation to the risk adjusted costs. So that purple line essentially. The statewide has been and continues to be plan with the riskiest members included, at least in the data set we use. That is at least partially driven by the fact that of the 33 members with greater than $500,000 or more in claims in 2020, 26 of those members were enrolled in the statewide plan. So their risk scores, when you think about that, is greatly affected by high cost claimants within the statewide plan in comparison to the rest of the plan. And that's not an indication or anything on Providence or anything like that. It's just high cost members tend to, across not only PEBB, but across all of our clients, they tend to pick some of the broadest network and richest plans. And I know state isn't necessarily the richest plan, but it is the broadest plan. And so that, as far as the network availability goes, and so that's not totally uncommon. I just want to call that out and say that high cost claimants do affect statewide more so than the other plans. So any questions on this section? Okay. All right, so let's look at a little bit more about trends by place of service. So facility specialty pharmacy was up 5%, physician office visits down 26, outpatient surgery down 23, and then inpatient costs were down 10%. On this facility, so this top line here, this facility specialty pharmacy, that includes outpatient medical drugs, professional medical drugs. So these are drugs that were basically injectable medications administered in an outpatient setting or a professional setting, as well as specialty drugs on the PBM. So that top category basically excludes, generic drugs, brand name drugs, but it includes all the rest of the drugs, both medical and pharmacy. So I just, again, calling that out. So that was up 5%. The rest of the categories were down significantly. And some of the, I can move on, but I'll let you, sort of digest sort of the reasons why in that blue box there. Allowed costs by service category. So again, this is looking at the various service categories on the left-hand side and what per member per year allowed amount change was 2020 compared to 2019. I do want to call out that there were only 3 service categories that experienced an increase in per member per year costs: mental health, substance abuse, facility specialty pharmacy, and then non-specialty pharmacy also experienced a slight increase. For the mental health substance abuse, so this was increased 5.7%. And this was really driven by professional claims. So what we saw in the data was that actually outpatient and inpatient costs related to mental health actually decreased. Substance abuse, so one component of that category, substance abuse, decreased 9.7%. But substance abuse actually, so out of that category, substance abuse only accounts for about 11% of the total claims. So mental health really does drive that category. Moving down to that specialty pharmacy, that facility specialty pharmacy line. So again, that includes outpatient medical drugs, professional medical drugs, and PBM medical specialty. So I have a slide here and a few slides that talks a little bit more about that. And then non-specialty pharmacy. So this was a little bit of a surprise to us that costs for non-specialty pharmacy, so this is brand name drugs and generic drugs administered through the pharmacy plan, that increased 2% year over year. And what we found actually was that was mostly a result of mail order. So retail costs, so basically 30-day prescriptions, actually decreased by about 3%. But mail order costs increased 16%. So the trend on that was actually driven mostly, again, pandemic related, people filling mail order prescriptions instead of retail prescriptions. And then a little bit more on utilization related to COVID-19. So we did see decreases in utilization across all categories except for 2, telemedicine, which is highlighted in that purple shade or that purple box, and then urgent care visits also increased. So naturally, some of the ER visits that we saw decrease went to urgent care instead, which is actually in a normal year and ongoing a good result to have. We want care to, if a member can get urgent care visit instead of an ER visit, that's obviously what we want them to do. And then, you can see how those compare to Mercer book of business. Okay, so a little bit about pharmacy trends. This continues to be an ongoing thing where we report on pharmacy trends. Again, PEBB is not alone, but it doesn't make it any less hard or easy to stomach, rather. So total drug in this top portion here increased 3.9%. So this again includes these 4 categories down here. Non-specialty PBM, so that's basically retail, mail order, brand drugs, generic drugs, excluding all the specialty drugs. That increased only 1.8%, so we're not concerned about that. The specialty drugs on the PBM, that increased 17.1% year over year. And I touched a little bit upon the statewide and the choice increases. So there were basically 3 or 4 drugs within both of those plans that A, saw an increase in the number of patients, and B, saw commensurate cost increases. So we know what those drugs are. The issue that not only PEBB is facing in your plans, but again, all of Mercer's clients is some of these drugs come out and they're new and innovative ways to treat certain, conditions. And a lot of times there's no therapeutic alternative to a lot of these treatment plans. So from a member perspective, it's really helping out the treatment from the member, and members are receiving a much better level of care for certain, for some of these specialty medications than they would otherwise have access to. The issue from a plan's perspective is obviously they cost a lot. And there's, some things that we can do, and the plans are doing it to sort of cut around the edges, so to speak, of these costs. But bottom line is, a lot of the pharmaceutical manufacturers have good leverage in some of these, negotiations or whatnot that take place. Another thing that is developing is some of these drugs, come out to treat one specific condition, but then as they get integrated and evolve, they come to be able to treat more conditions. So maybe there's a diabetic drug that, oh, well, it can also treat, hypertension or something else. So what happens is the list of treatments for one particular drug starts to increase over time as the manufacturer and the clinical community start to realize, okay, there could be different uses for this drug. And so that's why we continue to see number of patients using these medications increase year over year. And so that's really, both on the medical side and the pharmacy side, some of the issues. One thing that I do want to call out on this slide is this. So the specialty drug medical outpatient facility dropped significantly. And this has to do with a drug called Remicade. Remicade is a treatment used to treat rheumatoid arthritis, psoriatic arthritis, Crohn's disease, plaque psoriasis, and a number of other conditions. So it's one of those drugs that, it has a lot of different treatments or uses for. We noticed that drug was included as the top drug in this medical specialty, facility. So drugs administered at a facility setting. But it moved, it basically disappeared from the facility setting in the data in 2020. We still see it in the medical setting. So if I pull up my laser, so it's still appearing in the professional setting, but it vanished from the facility setting. And that has pretty much entirely to do with site of care. So over the course of 2020, early in 2020, Providence administered or began a site of care program that the goal is to steer drugs from a higher cost setting to a lower cost setting. And what happened, what we saw in the data was about $4 to $5 million worth of spend at the facility setting, not even get shift to the professional setting. It really just kind of went away, for lack of a better term, into that to number 3. And so what we think was happening is that site of care program from Providence, and MODA does offer a site of care program as well, is actually having quite a big of an effect on the PEBB data. So I just want to call that out. We implement these programs, 2 years prior, and it takes time to see it in the data, but it certainly is having an effect on overall spend. So overall, that we thought that was a good thing to call out, that one of your carriers programs is certainly working. Any questions on this?
So just to be clear, Nick, what you're saying is that the cost of the drug was mostly associated with where it was being administered versus the cost of the drug itself, because once it moved to another setting, we didn't see the high claims related to the drug.
Exactly. Yeah. And even in the data we have, Siobhan, the cost of Remicade is about half the price in a professional setting compared to a facility setting. I don't know the exact dollar amounts, but it basically gets cut in half when you move it from a facility to professional. So to your point, a lot of the costs that we were seeing in PEBB in 2019 and prior was mostly related to facility charges, marking up the price of the drug or other services, and moving them out of those higher cost facilities really did help as far as spend goes.
And I just have one other question, because I just want to ask a question about an assumption that I've made, which is, you mentioned that some of these specialty drugs, they find new uses for it. And my understanding is that often means that drug companies extend patents so that we don't have generics to bring down the cost. And so they stay really high in cost for longer. Is that correct?
Yeah, quite frankly, for a lot of the drugs they do. Yeah, I mean, that's what's happened with insulin, for that matter, for a number of years. And I know that's not a specialty drug, but basically extending the life of a patent, if you can find little deviations in either the ingredients that you're using or new therapies to treat, it does extend the life of a patent. Yeah. Okay, and I know we're running sort of short on time here. I'll just touch upon this clinical top conditions, and then I'll actually speed ahead to just sort of the top opportunities and recommendations. So, top clinical conditions: diabetes, osteoarthritis, pregnancy, newborns. So newborns shot up. So now it's number 4 in the PEB's top clinical conditions. It was number 11. And again, that's pretty much entirely related to some of the 1067 payment issues that we talked about earlier. Diabetes was number 3. It shot up to number 1. Osteoarthritis was number 1, and it moved down to number 2. And a lot of the claims related to osteoarthritis, were likely deferred in 2020. It may reappear in 2021 as sort of the top conditions. Depression did increase in total cost. Depression was number 5 last year, so it remained number 5 this year, but it did increase in overall total cost. And then just the top clinical conditions. So we highlighted a few of these, and we highlighted them because they're significantly different than Mercer's book of business. Now, that said, that isn't necessarily a bad thing. Likely what is happening in the mental health space is an underreporting. So it very well could be the fact that PEB's plans and members are more akin to getting and receiving treatment for mental health related conditions than other clients may be akin to do. But there's no doubt that PEB's prevalence of especially anxiety and depression are higher than what we see across our book of business. So that does lead us into some of our recommendations here in a slide or two. Low back disorder is another area. So musculoskeletal low back disorder is about 36% higher than what we see across our book of business. Okay, so I'm going to speed ahead. The low value care, I'll let the board members and the public look at this. Overall, no significant changes in either of these low value care slides from last time. So what we have on here is, so this is the last slide. We just want to leave you with some of what Mercer sees as the top opportunities and areas for improvement. The challenges associated with each of those areas and the recommendations. So the top 3 are unchanged from our prior report. So metabolic and cardiovascular, musculoskeletal and low back disorders, and then finally mental health. Metabolic and cardiovascular and musculoskeletal. So both Providence, actually all your plans, including Kaiser, have newly available resources for employees, especially on the MODA side. So MODA has MODA 360 now, where they have additional digital support for members who have metabolic and cardiovascular, including diabetes treatment. So that's part of what MODA offers now. Providence just added Kaya Health for 1/1/2022. So Kaya Health is a digital physical therapy app. So hopefully, again, the goal of all these digital health point solutions and then subsequently making sure that they're working correctly is diverting and prevention of some of these higher cost related services later down the road. So a lot of what the digital health therapy solutions and the point solutions that we've talked about for a number of years, that's the goal, is to try to divert, speaking of site of care, diverting care and trying to, prevention activities rather than treatment as they come along. Mental health. So I know, Sean, this has been on your radar for a few months now. One of the challenges with mental health is just making sure that people are aware of not only the plan's resources, but what Cascade Centers offers as well through the EAP. Making sure that members are using the EAP and that the EAP is making appropriate referrals and screening where possible back to the plans and whatnot. So that's one thing that I know we continue to explore as far as, burnout rate and then critical incident response to make sure that members are receiving care, especially again, a lot of the socioeconomic challenges related to COVID-19 and the other related issues last year, and continue to be. And then specialty drugs through the PBM and the medical. So we talked about those, but again, site of care programs do help. We saw that with Providence, with Remicade as the example. They do work and they do help lower costs. And then finally, the last one, delayed care and chronic condition management. So one of the things we need to continue to do is encourage proactive outreach to the people who haven't had their, your appropriate screening based on your, particular age range and gender, whatnot. And then what we'll continue to explore is that in-person versus telemedicine. So is telemedicine the appropriate modality for some members? Sure. But is it the appropriate modality for other members? That remains to be seen, and it's something we're going to continue to monitor. But with that, I think I'm a few minutes over, but a lot of information. Obviously, we have the full plan years. I will open it up to any questions.
Nick, this is Ollie. I just wanted to mention to the board that we attached the updated work plan through the end of this year, where we'll be addressing a lot of these opportunities and bring the carriers in to continue discussions, and as well as our recommendations from our PMAC committee. So there'll be a lot of good discussion in the next few months.
Okay. Well, I guess I left you all in stunned silence. So with that, I will defer back to Sean.
Thank you. Were there any questions? No. Okay. All right. I mean, I have many questions, but not for a short couple minutes. So we'll just continue to unpack this as always across our time. We are scheduled for a break, and so we're going to do that. We are 2 minutes over, so over our break, and I want to retain our entire 10-minute break. So we're going to start at 11:42 is where we're going to get started again. See you in a minute.
Hey, Sean, this is Kate. I apologize, but I'm going to have to go. I have an 11:30 that starts here, and it's going to go till 12:30. I don't know.
Okay.
So if you need me to join back in, I can. Let me know.
I don't think, Ali, I don't think we have a vote planned at this point.
No,
right.
We're good. Thanks, Kate.
Yeah, thanks for letting us.
No problem. Thank you. This was really interesting. Thank you, everyone, for all your reports.
Yeah.
Bye.
All right, everyone. Just no need to hang up and call back in, although you can. We're just gonna take a break. All right. Coming back from our break, let's go on to the next agenda item, Secretary of State audit.
This is going to be delivered by Cindy Bowman. This is part of our, I think we have three agenda items over the next few months to talk about our Secretary of State audit findings in the areas of communications contracts and then fiscal policy around our reserve. And just want the board to know that we are working on responses to those findings and just to give you an update. So is Cindy on?
Thought I just saw Cindy like moments ago.
Ollie, can you hear me?
Oh yeah, there she is.
Sorry, my as luck would have it, my wireless headset went out right before.
Oh no.
So now I'm on speakerphone, so I hope everybody can hear me.
Yeah, your audio is good.
Okay, good. All right, thanks. Okay, so I think I heard part of what Ollie was saying. We are going to talk about the Secretary of State audit recommendations related to communications only. As you know, I don't remember what year the audit was done, but we have been working with our Mercer team primarily to address several of the recommendations that they made. So I just want to go through that. First, a shout out to the excellent Mercer team, Aaron Ward, Sarah Berthume, and also Mary O'Laughlin have just been fantastic, and we're super excited about the work that we're doing. So I don't
Cindy,
yeah.
The presentation jumped off screen. Rose, can you share that?
I got it. Let's see if I can do it again. There you go. Is that okay?
Yeah. Thank you.
All right, let's hope it stays. Technology, gotta love it. So the first recommendation that related to our communications work was specific to collecting and analyzing and then sharing results with you to better inform your decisions. They were very specific to collecting customer feedback, mostly about benefits utilization and services around that. As you know, we do a customer service survey every year, and we do collect some information, but we have not specifically asked questions about carrier services like claims processing and so on. So as you can see, we are going to work with the carriers and kind of design a report so that we can gather more of that information. The OWEB customer service survey also has some questions specific to claim utilization and services. So we are also going to expand our survey so that we can gather some of that information there. One of our other opportunities is through the new benefits system. We do have the ability to sort of track customer service member phone calls, but it's kind of wonky, and we don't get really good information from it. But the new benefits system requirements do include tracking and reporting customer service member phone calls. So we will be able to gather more information and then share that with the board. So recommendation number 2 was to improve our communications overall. The audit team felt like we do a really good job around open enrollment, but maybe not so much the rest of the year. So this is where we've really done a lot of work. Specifically with our employers and stakeholders, we pre-COVID did a quarterly meeting with kind of agency benefit staff. They were called the PEBB Information Exchange, and then COVID happened, and Anyway, we had a hiatus in 2020, and we are resuming those this year. During the meetings pre-COVID, we, kind of highlighted a little bit of what the board was working on, but we didn't really go into a lot of depth on that. We plan to really expand that agenda topic, talk more about the decisions that you make, how you make them, kind of what goes into that. And then also offer those stakeholders an opportunity to provide some feedback to you if they want. So we're excited about that. I would expect I know for sure pre-open enrollment that we will have a PI meeting that may really focus on open enrollment, but it will give us an opportunity to kind of talk about the decisions that you made at renewal and how that plays out for the upcoming year. We also have been working on creating some new communications for our members. So this is where our partnership with Mercer has really come into play. You may have seen, I think we try to copy the board, but if you're not getting it, let me know. We've designed a new monthly newsletter. I think June was the first one we did. Maybe it was July. We had a few technical issues with it. Anyway, we decided it kind of highlights benefits. We have wellness events. So those are wellness events that our vendors offer. EAP, there's a lot of, we just ask our vendors to send us information, our carriers, and then we kind of promote those wellness events in this newsletter. This month, we have started a Working for You section in which we're going to share board highlights, kind of what you're working on. Again, we're going to introduce the board to our members, kind of talk about what you do, and then from month to month, we'll kind of highlight something that you're working on or provide some more information about how you do your work and what you look at. In addition to that, we're going to update our board webpage to expand that content. Right now, that I'm going to tell you, that webpage sort of primarily has information on these meetings, a streaming link, and then the documents that you look at during the meeting, and that's about it. So we really want to beef that up and share more information with our members. So let's see. So we talked about the monthly newsletter. In addition to that, we are going to introduce some Benefits 101 instructional videos. Member education was a key component of the audit recommendations. And so we'll be posting some how your benefits work, pretty much, what's a co-payment, what's cost share, and there will be a little bit more on that. We're going to talk about Jellyvision and the Alex tool, and so I'll be able to expand on that a little bit. We're also partnering with Uplift Oregon, that I believe is specifically working with SEIU. So they are supporting new state employees onboarding. So they have established some trainings and are sharing resources to kind of explain our benefit package and help members really understand what great benefits we have as state employees. So
hey, Cindy, Cindy, it's Siobhan. I just wanted to interject on Uplift. I know that they are starting to see a lot more folks go through, a lot more new hires, because they've been doing a lot of piloting and now they're picking up more people, which is great. Asked me to participate on the trust, and they have a seat on the board. And I just was suggesting that that's another avenue to talk about the vaccination incentive, particularly if it's extended, just to let new employees know about that incentive. Thanks.
Oh, that's great. Okay. Yeah, thank you. So Siobhan, has anybody talked to Uplift about that, or do you want me to introduce that to Kelly? I can chat with her.
I think would be great if you introduce it. I mentioned it to one of our board members too, but if you do as well, I think that would be great.
Okay, happy to. That's a great idea. So what they offer now, and we meet with them probably at least once every 2 weeks, and in a variety of different areas. They meet with us in Mercer, and we're really trying to collaborate on not just new employee training, although that is the initial focus for the trust, but they are finding that existing employees are also interested in kind of getting more information about their benefits. So they've had so many people try to enroll in their classes that they've kind of had to take the focus back to new hires, because that's really the target audience for now. So it is a weekly 2-hour training. They have about 90 minutes of content and then 30 minutes of the union orientation for the represented positions. It is not exclusive to represented staff, though. Anyone can attend it. It is, as I said, designed for new employees, but of course everyone's welcome. And their goal, and hopefully, well, the goal is mandatory training within the first 14 days of hire. Ideally, from our perspective, that training would happen within the first couple days of being hired, because as you may or may not know, benefits are prospective the first of the month following the date you enroll. So if you start work on the 29th of the month, for instance, you only have a couple days to get your enrollment in so that you're covered for the first of the following month. If you haven't had the training, you're sort of, making your enrollment decisions based on sometimes your best guess. So ideally, we'll have that training. It's at this point a lofty goal, but hopefully someday we will get there. The trust does work with DAS, excuse me, so they're very involved, and I think that's kind of where we'll need to target in order to move this timeline along. But for now, their goal is really the first 14 days of hire. As I mentioned a few minutes ago, we are expanding our open enrollment decision-making tool. It's called ALEX Advanced. So you are probably familiar with the ALEX tool. You can go in and you can choose your location and choose kind of, do you want to have a broad panel of providers? How often do you think you're going to go to the doctor, and so on? And then it kind of helps you walk through what plan might be best for you based on cost and service utilization. This year, they're expanding it, so we're going to promote some of our chronic care and wellness programs. We're working with them. I just met with them earlier this week, last week, time flies, to talk about what chronic care programs we want them to promote on our behalf. So we're still working on that. They are designing a new PEBB-specific customizable, easy for me to say, URL, and that's going to include those on-demand videos, health 101 type things. It will also have a wellness page, links and resources for that, as well as an FAQ. So this is brand new. I've seen kind of a demo of it, but haven't really gotten a chance to see the PEBB version of it. So I'm excited to see that, and I'll definitely share that link with all of you so you can take a look at it too. So we do have the benefits instructional videos, the monthly newsletter. Also, Mercer is working on designing a dedicated on-demand new hire resource page. So right now we really have a lot of information out there during open enrollment season. We have the enrollment guide, the ALEX tool, all of these resources for current employees who are going through open enrollment. We want to offer the same resources for new hires, kind of a one-stop shop so they can go there, get information on training opportunities, the educational videos, and then what their enrollment resources are. So that they are working on right now, and I'm not sure if we'll have that done. Hopefully we'll have it done by the end of the year. I can't remember our target date for that. And finally, the Health Equity Work Group has established, has created this health equity tool. And honestly, I'm going to just tell you right now, I know very little about it, but hopefully Brian or Teresa are on the phone and they can kind of describe that if you're more interested about that. But the goal of this is to make sure our communications, our educational resources address equity and they're accessible to all members. So I am in the process of learning more about that myself.
Yeah, this is Brian. Just a quick note. Yeah, Mercer's really taken the lead to partner with staff to develop this health equity screening tool. And what the tool does is for any recommendations, coming up through staff or PMAC or the coordinating council, the tool just asked a pretty large number of questions that speak to health equity and other considerations, and essentially forces staff to ask all the right questions before we even get to the point of proposing something to the board. So it's just making sure we're actively looking at this stuff through the health equity lens rather than taking a more kind of piecemeal policy approach to it.
Thanks, Brian. I knew you could help. I think that might be it. It definitely is. Do you have any questions? Any thoughts, suggestions?
Any questions from the board?
All right, well, thanks very much.
Thank you. Just a brief note here. We are scheduled our meeting to go to 12:20. I know you probably got most of you probably got a pop up on your Teams if you're joining by Teams that the meeting's going to end in 5 minutes, but I don't think we're not going to be kicked off the video. Just stay on, and that's just a mismatch between the agenda and the calendar invite. So ignore that. So the next agenda item is an update on the innovation work group. So I can start with that. Just making sure. Yep, that's right. So yeah, some help on this agenda item would be great.
Hey, Sean, Margaret's on. Would you like me to chime in and get us kicked off?
Kicked off would be amazing. Yes, thank you.
You bet. So just to kind of quickly run through and update the board. So the innovation work group is actually officially on hiatus from public meetings for the summer. However, there's quite a bit of work and process going on in the background, and there are several major work streams. Rose, if you're able to give me control, I can put up the innovation work group's most recent work plan. Otherwise, I can just speak from my screen, and the work plan is something in the innovation work group reviewed at their last meeting, which was on June 15th. So it is posted on the website with all of their public meeting documents. We can also certainly circulate it to the board as well. But in terms of what the work that is going on this summer that's in process and is planned for fall, and the next innovation work group meeting will be on September 21st. So still a couple of months to go with all of the work that is going on. But there are a couple of main topics that are on the work plan for fall, and a couple of them will be coming to the board at some point in later fall for input and decision recommendations. But one of the first topics the work group is tackling is related to the hospital payment cap, and there's a couple of work streams going on here. One of those is just a general audit of year one CAP implementation and the financial impact. And so that's more of a financial look at payments under the hospital payment cap to ensure that payments stayed within that upper bound of 200% of Medicare rates for network hospitals. And also an updated look at the savings recognized from the cap. When the cap was implemented, the most recent estimate prior to implementation was that the cap would yield a combined savings of approximately 81 million for PEBB and OEB. And so part of the data review will be doing a refresh of that to look at the actual savings recognized. Second to that, there's some additional analysis work going on related to the hospital cap, trying to look at the delivery system impact, in particular utilization patterns, comparing them at capped versus exempt hospitals. If you'll recall, there is a significant portion of hospitals in the state that are not under the cap, and I believe when we looked at the data, the numbers were around approximately 40% of PEBB utilization happening in uncapped hospitals. Don't quote me on that exact figure, but it was somewhere in that range, over in the 40 to 50%. So part of the utilization impact analyses that the innovation work group will be looking at utilization patterns and trends, including at capped and uncapped hospitals. Now, I do want to preface that analysis by noting the team is doing some initial work looking at the data, but as we all know, utilization data in 2020 had a lot of things going on within the greater ecosystem that impacted service delivery and the types of services that were delivered and levels of utilization. So I think we're proceeding with some data mining relative to the cap, but I think we'll want to be prudent about drawing conclusions in terms of what utilization impacts we see and how those may or may not relate to the hospital payment cap. And so to note, for that payment cap work, both Mercer as well as OEB's consultants at Willis Towers Watson are sharing portions of that work and contributing to the overall product. In addition to the hospital payment cap, we also have some work underway that's going to involve looking at gap analyses related to several specific areas of care the innovation work group identified. And specifically, these gap analyses will look at how are current carriers for PEBB and OEB providing services and managing the population relative to identified standards or best practices that we want to be moving toward. And the particular areas of care that the innovation work group identified are around health equity. So there will be doing a health equity assessment and gap analysis with carriers. Second topic that was identified was around behavioral health. And in particular for behavioral health, it was around mainly network adequacy. And then the third area was around primary care and behavioral health and payment models, in particular looking at progress on value-based payment approaches and models in that arena. So Mercer is going to be leading that work on those gap analyses. We're going to be having a kickoff meeting in early August to get carriers kind of up to speed with the project and moving forward with the work. And the innovation work group will be looking at the outcomes and results of that through the fall. One additional area of work that is currently in process for the innovation work group, and Willis Towers Watson is leading this particular project area, and it's around the Centers of Excellence program development. We had given the board an update a couple of months back regarding the innovation work group's identification of musculoskeletal conditions as an area where a Centers of Excellence program could potentially bring significant benefits to PEBB and OEB in terms of both around quality and improving outcomes, and as also around cost as well. And so we are having that work stream is in process on the COE program development. We're having regular meetings with the carriers to begin to lay out the specifications for the program. Identifying candidate providers involves looking at identified volume thresholds, quality indicators, and then further downstream, once we look through those filters, that we'll be looking at the cost arrangements and payment bundles in terms of identifying providers who meet the criteria we've established in those areas to potentially participate in the program. So I anticipate that as we get into later fall, the innovation work group is going to be coming up with some recommendations that they'll want to bring forward to the board around particularly around the gap analyses and where there are opportunities for improvement, and also with regard to COE, potential COE program implementation as part of the benefit design. So that was a lot of information all at once, but I'm happy to answer questions. And Sean, if you have anything additional to add, please certainly do so.
Yeah, that's what I was going to say. Thanks. The only thing I would add was, as you can tell, there's just a lot of work in that it's directed at some of the items that came up today. It is, I'm excited about the being able to take a deep dive into some of these issues and come up with some solutions, potential solutions that the board can actually act on, and digging into, when we're going through all this information, there's only so much time to just kind of absorb it. Whereas the innovation work group can kind of dwell on an item, centers of excellence, or some of these equity questions, that we were just hearing about. So there's a lot of potential there, and I'm looking forward to having those conversations with the board when we have more information in the fall. Are there any questions from the PEBB board as far as anything you heard, a little more detail about any of the work plan items for the innovation work group, or a go back, or just you want to hear something one more time, clarify? Okay. Hearing none, we'll keep you updated with these regular updates from Innovation Work Group, and then there will be some dedicated time and agenda items coming out of the Innovation Work Group this fall, as Margaret just said. So look forward to those. Thank you, Margaret. So if nothing else on that, we actually are exactly on time to ask for public comment. Is there anyone, do we have any scheduled, or public comment, or people on the phone that would like to give public comment?
Sean, I don't have any scheduled public comment.
Okay. Would anyone like to unmute themselves and speak up?
Sean, before you adjourn, I just wanted to give the board a quick update that the consultant RFP will be released in mid to late August. So I'll be on the lookout for that, and we'll let the board know when that does get released.
Okay, good to know. Thank you. Is there any other business for the board? All right. Hearing no public comment and no other business items from the board, we can adjourn our meeting. Thanks for your participation, everybody, and your attention.
Thank you. Thanks, everyone.
Thanks, Sean.